Well, thank you, Ben, and thank you, everyone, for being here tonight. Tonight, I'm hoping we can have a conversation and not just sort of have the three of us surgeons talk at you guys. We are launching something right now which I think is really big. I think it's the most exciting event in reconstructive surgery in quite a long time, and that's the Rialto posterior oblique SI fusion procedure. And I hope at the end of tonight you guys will be able to understand who it is that gets SI joint disease and potentially needs an operation, understand what are the various approaches that are available and out there right now, understand how to make the diagnosis, and understand even how to do the Rialto procedure. I'm joined here by faculty who have extensive experience with the procedure that I've been involved in developing for at least the last 8 years. And I think between the three of us, we can generate the basics of a conversation which is going to continue for a long time after we leave this room tonight. As we sit here tonight, the SI joint has, for the first time in quite a long time, become a topic of conversation in the medical community. And I know many of the people online tonight are medical professionals, and others are patients who are suffering from this disease. But it's only in the last several years that you hear anybody talk about the SI joint. And so what I thought it would be useful to do was take a step back and just without getting into archaic citations, talk about what happened to the SI joint over the last 50 or 60 years in medicine. There was a feeling for a long time that the SI joint was a very important generator of back pain. And back pain is loosely defined. Sometimes it's the flank, the buttock, the hip, or even the middle of the low back. In fact, 100 years ago, people thought that the SI joint was the primary cause of low back pain. And people wrote about it and tried to do operations to solve what is a very, very common and important health problem, which is chronic low back pain. The intervertebral disc became a much more popular explanation for back pain and gathered a lot of attention beginning a couple generations ago. And the SI joint became less prominent, but it was still something that people thought about and people operated. Unfortunately, the operations and the technology that was available to surgeons a generation or two ago was not adequate. And the experience that surgeons had was very poor. It was so poor that I think an entire generation of surgeons, certainly everybody my age, was taught, don't operate on the SI joint. You cannot fix it. The operations don't work. So I went through an entire neurosurgery training residency at Stanford without ever operating on an SI joint, although I did see patients that I thought had SI joint pathology, and they told me just, Carter, it's a mistake, don't mess with it. And so what we all did, and I think you guys would agree that this is what everybody did for decades, was send these patients to the pain clinic. And sometimes they were sent to the pain clinic and they spent a long time there and got progressively addicted to narcotics and progressively difficult to manage their chronic pain. And the patients actually got a reputation of having something more psychologically wrong than physically wrong. I've always been a big believer in listening to my patients, and I've always wanted to challenge myself that when I didn't understand a patient's pathology, to try to seek it out and figure out what's wrong, and rather than blame the patient for my lack of understanding, blame modern medicine and say, well, what can we do differently? And so what happened probably 15 years ago was we got very, very good at working on the lumbar spine, and I think all of us got to the point where we could reliably and consistently make lumbar spine patients better. And when we had failures, we sought an explanation for those failures. And what started to happen was we all started to notice that this patient I can't get better, and the reason I can't get this patient better is the SI joint. And I think a lot of us were very frustrated with these patients because they were patients that you wanted to help, and you had a hard time finding an answer. And that's what's led, I think, right now to the resurgence of interest in SI joint is that these patients are sticking out. It's the last joint in the human body which has been unsuccessfully treated until now. And I think what we're presenting tonight is the answer. I don't think that there is a better, more effective, safer operation that is out there right now. I think it's truly exciting, and it's an opportunity to help people with very chronic and disabling symptoms. What do you guys think? The medical community, I think, is still a little bit divided about the SI joint. What is your experience back home right now?
Well, I think like us, we weren't exposed to the SI joint symptomatology. We weren't exposed to how to diagnose it, how to work it up in residency and training formally. And so we became, I think, practitioners in determining the root cause of some patients' back pain as being SI joint mediated as we educated ourselves slowly. And then with time and experience, watching our patients who we would have perhaps several years ago written off as failed back, quote unquote, or a patient with psychological problems because their imaging studies showed that their fusion was absolutely perfect. There didn't seem to be any other discogenic cause for the pain, and yet the patient continued to have this type of low back pain that seemed to be resistant to pretty much any other treatment. When you finally find the pain generator, the cause for this, and are able to successfully diagnose and treat the patient, it's hard to not at least pay attention to it.
It's sort of a dramatic, gratifying thing when you have a patient who otherwise you would have sent out of your office to have them come back with a smile on their face and say, "Doctor, thank you. You changed my life." And I have stacks of letters at home from people who are saying just that. Yeah. There's something very dramatic which happens. Dr. Rouben, what do you think?
Prior to about 15 years ago, and having been trained as a trauma orthopedist initially, we had many patients that came in with a fractured pelvis, and they had disruption traumatically of the SI joint. So we had to do something for it. And what we used to do in the bygone days is we used to take a big threaded bolt and let me see this little. And we used to tag that bolt from here to there and all the way through. And then this being the sacro-iliac joint, we used to cinch it down, and that would structurally stabilize the patient. However, the cure was more symptomatic and more troublesome than the problem itself.
And that was because the surgery was morbid intrinsically and destructive?
It was so heinous and disruptive to normal anatomy. And so once we appreciated the fact that we could access the sacro-iliac joint anyway, that minimized the destruction of normal structural tissue, once we accepted the fact that the SI joint was a true point of pain, instead of something to be forgotten, to be denied, and not even to be considered, once we acknowledge as physicians that the sacro-iliac joint is a dynamic physiologic component of normal human activity, that it becomes very loose and lax during pregnancy and as a means of allowing delivery of a child to the pelvis, that it's not just this stuck, solid, immobile, dysfunctional entity. So there's so many reasons why people will have pain, and so many reasons why our fellow peers and surgeons should consider the sacro-iliac joint as one of the many, but a significant consideration of why patients have persistent sacro-iliac, which you've always heard, the patients come in and say, well, my sacro-iliac's out. Well, it's because they have low back pain, but it's a general layperson's term to describe persistent chronic pain, regardless of whether they have facet disease or the disc disease.
Well, what I like to say is the most common complaint is flank pain. It's sort of somewhere in between the back and the hip, and the patients will usually describe it as a hip pain, but we all know that hip pain generally is an anterior groin pain, and so when patients are coming in with this flank pain, it could be the L4-5 facet joint, it could be the L5-S1 facet joint, it could be the SI joint, it could be a posterior labral tear,
or a kidney stone.
Or a kidney stone. And so, but the important thing is to have this diagnosis as an option in, most common failures in medicine are related to an insufficiently broad differential diagnosis. And I think up until several years ago, almost all spine surgeons would not include the SI joint in the differential diagnosis, or if they did, they would just say, yeah, your MRI of your lumbar spine is normal, and you need to go to the pain clinic.
We just simply didn't have a response to proven and confirmable sacro-iliac joint pain.
Yeah, and I think it's also very understandable, considering that most of our residencies, the MRI, the CT scan, took a big role in terms of diagnosis. And this is a particular problem with the SI joint, that oftentimes these particular imaging modalities are not sensitive to the pathology that the patient feels.
And that's what I like to say. And what I'd like to do, actually, just by way of a little bit of timeline here, I'd like to go through some basics of diagnosis, patient selection, and those sort of things. And then what we're going to actually do tonight is we're going to look at some videos of real surgery with these two excellent surgeons at the helm, and we're going to get to see the procedure done on real patients. But before doing that, for those people who are in the audience who have some interest that maybe there is something to this SI joint fusion surgery, maybe there is something to the diagnosis, I wanted to talk about our experience about who are these patients, how do they present, and what are the most common complaints. And I'll lead off and say, to my eye, they're people with flank pain. They almost all go like this. Many of them have sciatic distribution pain that is not explained on an MRI scan. Sometimes they have hip pain. They often complain of clunking or an instability when they walk. They complain about sitting intolerance most frequently, is in my experience. But the symptoms are fairly complex, and I think there's a pretty broad range of symptoms that you can experience. And that's not unsimilar to the lumbar spine. People with lumbar spinal disease sometimes have pain but no numbness, or they have numbness but no pain, or they have weakness but no numbness or pain. So there's variation, and it's very much true with the SI joint. But the SI joint is a great mimicker, and it can very much look like it's a herniated disc, and then you get an MRI scan and the lumbar spine's normal. What do you guys see?
Yeah, I agree. I think that any of the symptoms that any of us will describe could be attributed to other causes, could be attributed to anything from kidney stone to hip pathology or lumbar discogenic pathology. This is a diagnosis that requires a physician. You need to think about this. It's not a recipe, like many things in medicine aren't recipes. But it does represent another tool in our toolbox to allow us to, for the first time surgically, I think very easily help patients that in the past have sort of wandered from pain management to pain management without a definitive cure.
I think you're obligated as physicians to consider that when a patient comes in with persistent chronic or recurrent pain, and whether they've had a good solid fusion that goes all the way up the thoracic spine, or you confirmed that there is no facet disease as a source of pain, and you confirm that it's not discogenic pain through the ancillary studies that are available to us, when you confirm it's not indwelling metal irritation, and all the plethora of things that could represent chronic recurrent pain, and appreciate the fact that we as physicians also must believe that our patients do hurt, that you can't presume because you're the 20th doctor that they've seen that the other 19 did what you could do. And you just have to look at each patient and assume that they're telling you the truth, and then give them some belief. And if they come in, and this being the back, as we know, and they keep consistently putting their finger right at what we call the lumbosacral notch, either on the left or the right, that you better consider as one of the possible etiologies, sacro-iliac joint. And remember that in the front, for all those who haven't been to anatomy class lately, the sciatic nerve is right in front of the sacro-iliac joint, that the most peripheral aspect of the sciatic nerve at that level is L5. So patients will often describe radicular pain of which there is no other explanation. They have normal pristine disc. So you're going to see somebody that comes in with that consistent pushing on the lumbosacral notch, and I think you're going to see that as the most consistent explanation for their misery, that all of the other diagnostic examinations of compressing the pelvis and rotating the iliac wings are at best hit or miss. We're trying to convey that this is real. We do have an explanation for it, and we do have a simplistic, what we think is a simplistic and safe treatment for it, which we'll get into.
So that probably leads us to pathophysiology, and what I've always said is, what's happening here, and my honest answer is I don't think anybody knows for sure. What is very likely is that there is the sacro-iliac joint moves very little, a couple of degrees, I think, in normal individuals. But what is likely is that there is some ligamentous laxity, particularly in women, particularly in perimenopausal women or women of middle age, who maybe through changes in their hormonal environment or from a difficult childbirth or some sort of issue like that, have developed a little bit of instability, and it's a micromotion. And that micromotion leads to chronic tendinitis and ligamentitis in and around this very richly invested joint. It's a very big joint, and that is what generates the pain. We've been hard-pressed to prove what the motion is, but very likely the sacrum is sort of rotating a few degrees, and it's mimicking childbirth. It's rotating out of the way, and there's sort of a gull wing, I'm going to age myself here, but like a DeLorean, a gull wing expansion of the sacroiliac. Don't you guys think that's what primarily the pathophysiology is?
It seems to be. It seems to be very likely because we see this after, oftentimes after trauma, which arguably childbirth could be described as to the pelvis.
I had a 40-year-old man who came in the office. He was salt of the earth, fireman, family man. He had no red flags. He was a good guy, and he slid into second base 2 years before I met him, and he had back pain. His complaint was of midline low back pain, and he had a normal lumbar MRI scan, but his back pain was intractable, and it was disabling him. And one of the physical therapists had picked up that it seemed like it was the SI joint. I don't think I would have thought of it, but the physical therapist had picked up on it, and they had injected the SI joint, and the guy's pain went away. For the first time in 2 years, he was pain-free after an injection. So that sort of brings us to talking about who are these patients. Well, occasionally it's a 40-year-old firefighter with a funny slide into second base, but most of the time it's women. In my practice, it's 80 or 90% women. How about you guys?
I think that's consistent.
And I think that's because the female pelvis is intrinsically different, and it's structured to be able to move at childbirth. In my practice, the patients typically are middle-aged. Like with most degenerative arthritides, they are sort of middle or later middle age.
Yeah, I don't have too many young patients suffering from this. My skew of female to male is probably a little less than you guys.
And I may not be as good at diagnosing it in the men or think of it often enough in the men. I may be biased because the most obvious examples seem to be women. But and then the other population that we all see because we're busy spine surgeons are people who've had multi-level spinal fusion, and it essentially is a form of adjacent segment disease, which is taking what would have been a patient with a very good result and having them in the ER regularly.
That's right.
Any other patient category?
Well, I think, again, to reiterate, always look at your patients who've had trauma, look at their patients who have had difficult childbirth,
Or multiple.
or
childbirth.
multiple, and or they had extra big children, and they talk about it and brag how their child was so big. Look at people who have had fusions, and of course, every solid fusion is solid, I'm sure, but you have to really take in consideration that if somebody has a well-structured and a good sagittal reconstruction through a fusion, and their pelvis has a proper pelvic position in space, and everything just looks right, and by process of exclusion, you still have somebody with pain, don't blow them off and send them to the pain management, because then they'll never come out of that. And you've relegated them to chronic frustration throughout their life, and it disrupts them. At least give them the benefit of the doubt. Consider SI joint as a possible and plausible explanation, not only for midsacral pain, but for lumbosacral midline pain, for pain that's either one side or the other. Don't forget the anatomy of the sciatic nerve at that point. And don't get frustrated with them. Remember, our obligation to all of our patients is to help them with their pain.
All right, Dr. Rouben, so that leads us to how we make this diagnosis. And we discussed earlier, the three of us still have some differences in the way we make the diagnosis. Can you briefly tell me how you would go about making a diagnosis?
Well, remember that all local anesthesia is not the same. That basically, if you talk to your pain specialist, you talk to your anesthesiologist, that there's the xylocaine and lidocaine chemical family, and then there's the bupivacaine and the carbocaine, which are the long-lasting members of a different chemical family of local anesthetics. The first are quick to onset and quick to go away. The others are slow to onset, but they last for a long time. And there's about 15 to 18% of all patients and all people in our United States that have a genetic lack of tolerance or responsiveness to the short-acting anesthesia. So when you ask either yourself or your pain management physician or somebody else to ideally test the sacro-iliac joint under CT or fluoro guides, confirm the needle is in the joint, put some dye in there, prove it is, look for degenerative pathology, look for abnormalities, but also make sure that they just don't put the short-acting, that they use both short and long-acting, and then you're going to wait 2-3 hours after the injection, and then ask the patient whether it helped them or not.
Okay, so that you're describing an interarticular injection that
Absolutely.
is CT guided or fluoroscopically guided?
Whichever it takes, but you must prove it.
And so you have a clinical suspicion based on history and physical and exam in the office. You've ruled out a spinal cause, a common cause like an L5-S1 disc herniation, and now you've sent them for an injection, and that's that. So they say, Doc, it felt really good?
Well, one point before you start, though, I think is David Rouben here. He said you have to prove it, and so an arthrogram is critical, because we did mention CT and fluoroscopy, but specifically an arthrogram to make sure that we've covered most of the joint, I think, is critical.
You must prove you're in the joint. You can't have a picture and just say, well, I'm in the joint. You have to prove it's in the joint. So
And I think I remember you saying that you require a confirmatory second injection.
Well, in our geographic area, the standard at this time is that the injection is done, you have a positive response, you wait a while, ideally the same physician performs it in the same fashion using the same medications, and if you get two separate events and they both consistently give you a significant relief of pain for that period of time that the longevity of the local anesthetic is to last, then that's considered confirmatory, and all those who would question the validity of the whole process will back off and accept that as a standard. But at least that's in our community. It may not be in other parts of the country right now.
How about you, Dr. Benalcazar?
Yeah, I only insist on a second follow-up injection if the first injection, either I believe that the patient didn't really understand my instructions, because I think it's very education sensitive in terms of how you educate the patient as to what it is that you're looking for. Oftentimes I've had the patient receive the injection. Again, this is my fault. receive the injection, and go home and take a nap. So then when I see the patient again in follow-up, I say, well, did the injection help? And the patient says, no, it didn't. And then I say, well, why don't you explain that to me? Walk me through it. Tell me what happened. Well, doc, I got the injection like you asked me to do, and I went home and I took a nap. And so I can't tell you if it helped, because by the time I got home, it hadn't had the onset yet, and by the time I woke up, it had worn off. And so I take great pains in educating my patients now and letting them know what it is that I'm looking for. Essentially what I ask them to do, and I know I'm getting a little off the question here, but I think it's important. Essentially what I ask them to do is to identify some type of activity, some simple motion, whether it be getting in and out of a chair, or perhaps taking a step up onto a step.
Something that would typically be painful.
Something that would trigger their pain in the particular area, right? I don't want them to say bend over and touch their toes, and it triggers neck pain. That's not what I'm asking for. I'm asking for this particular type of pain, usually unilateral, lower back, top of the buttock, extending down the leg sometimes, maybe even sometimes into the groin, right? It's possible. I want them to be able to cause this pain for themselves with a simple activity that they have to be able to do in the office. One of my favorites is vacuuming. And so for a time, I was thinking about purchasing a vacuum cleaner for the office so that they could actually do that.
No one wants to vacuum.
No.
I don't.
Yeah.
They can all golf, though, regardless.
Oh, yeah, always golf.
So anyway, and then I tell them very clearly that I'd like for them to do the activities before they receive the injection, write down what their pain level is for each activity, and then we're going to repeat that again after the injection has actually taken hold. Because of the long-acting local anesthetics, as Dr. Rouben mentioned, that may not be an hour after the injection. So it's important that they don't just get the injection and try out their 3 or 4 activities and then say, no, it didn't work because the local anesthetic hasn't had a chance to work yet.
Have you all ever had a false negative because they got sedated? It's the same. It's a look-like when they won't go to sleep.
No, I haven't. I haven't had that
Some of the
yet.
people in our group or in our area will sedate them so they don't cry out because the needle goes in.
Yeah.
And then they're asleep, and by the time they wake up, well, then the anesthesia's.
Or a false positive, they gave them fentanyl, and they said, yeah, I felt great for an hour.
That's right.
Right.
Yeah, no, I ask the pain management doctors in my area. First of all, I use primarily 2 of them, the ones that I know have done this before, the ones I know they know what it is to ask the patient, they know the whole sort of procedure. So they become partners with me in the diagnosis of this patient, and neither one of them sedate.
So in both your case, the sine qua non of the diagnosis is a positive response to an intra-articular injection of long-acting analgesic anesthetic.
Yes, but there's 2 aspects to that. One is the length of time, and the other is the depth of the response. And for me, the depth of the response is much more important and significant than how long it may last.
So if they say, Doc, yeah, maybe I was a little better, that's not a positive.
It's not, no.
If they say, Doc, it was like a light switch, that's a positive.
Yeah, it was a wonderful, life-changing thing. Boy, if this could be permanent,
right,
it would be, a great thing for me.
So I'm yet a little bit different than either of you. I have them inject local anesthetic and steroids, and I try to observe their response over the next several days, which is the same thing I do for facet-mediated back pain. And I find that the patients who say, I got 4 days where I really felt good, that those respond the best to surgery. I've spoken to a number of SI joint surgeons over the last several years, and I've been to some SI joint focused conference, and I can tell you that I think right now, in 2016, a response to local only is sufficient to make the diagnosis. A dramatic response to local only. Many people repeat them like Dr. Rouben does. I like to see the steroid effect too, but I will still operate based on a local only effect. All of this is to say, though, that nobody's talking about making a diagnosis on MRI, CT, or plain X-ray, or even dynamic plain X-rays with flexion extension.
Right.
And it's my belief at this point in 2016 that this disease is, for the most part, radiographically occult, and that for the most part, there are no sensitive and specific radiographic markers for SI joint dysfunction. You guys, any comments on that?
Other than to agree with you, I haven't found the imaging to be sensitive enough. Certainly not flexion extension of the pelvis.
And certainly not without an associated traumatic event that would, show the irregularity, the inconsistency, the lack of articular closeness. And something would have to have happened, but you're correct.
So you do see abnormalities in the sacro-iliac joint frequently on all of these imaging modalities. You see sclerosis in the joint. On CT scans, you can see gas. We have a question.
No, continue. This is a great conversation, and thank you for all this information. I wanted to point out two things. One, out of our polling questions, one of the questions is if you are not treating SI joint pathologies at this point, why? And just wanted to let you know as a panel that 70% of our online audience does not currently treat SI joint. And so I wanted to make sure that we spend enough time on the diagnosis, because this is fantastic information. That was the number one request. They wanted a better understanding of SI joint diagnosis. And then there is a question that came in about in regards to SI joint injections. What is the shortest length of time that you would consider a positive response?
I have an answer, and I'll just say it's sort of in the eye of the beholder. It's if you have a patient that you really believe in, who everything else is consistent, and the duration of response is relatively brief, taken together, you might take a shorter length of time. With a patient who you have concerns about drug habituation or their personality or secondary gain or something like that, you might want a much more dramatic response. And so I would say that length of time varies according to the clinical picture.
Absolutely. Again, in the eye of the beholder, this is the patient who's suffering. This is the patient that I think is going to tell you how significant this result has been for them.
We have, and has been described, multiple means and methods by which possibly physical therapists and other first-line assessors of chronic pain can utilize as a maybe it is, it might be. I think that it is a diagnosis of exclusion. We are certainly much more confident and comfortable negating the legitimacy of facets as being a source of pain. We are certainly more confident and comfortable at identifying whether a disc is a source of pain. We have radiographic ways of determining whether the low back in any way is a source of pain, and we've highlighted that. But you also know the pharmacological physiology of the specific local anesthetics that we're using. You also understand the pharmacologic physiology of the type of steroids that are available. This is not just going to your local store and picking something off the countertop. We have to use the science that we know, and if done correctly, and if it's proven to be in the joint, you know how long a local anesthetic, especially the long-acting one, should last. You also know whether it's water-based or colloidal-based, whether a steroid is going to be a short actor, a long actor, whether it's pH, is a good pH for the patient or not. You just don't, it's not a cookbook. You have to, you have to go back to your medical school and pick up the pharmacological text, talk to your friends, and figure out what this is all about.
So the getting back to the radiology, so there is a lot of radiographic pathology visible in the SI joint. Sclerosis, vacuum deformity, just like you see in a bad disc. Those things do not specifically correlate with the syndrome right now. There are many people who have those abnormalities and have no symptoms, and there are many people who have symptoms and do not have those abnormalities. It's interesting to look at, and I certainly mention it when I'm discussing the workup of the patient, but as far as I can tell, they're not sensitive or specific. There is one scan that does show painful SI joints. The problem is it's a very small fraction of the people, and everybody remembers the Mercedes-Benz sign on a SPECT bone scan where there is sort of this V-shaped highlighting inflammation in the SI joints on a SPECT bone scan. And that is a true positive result. It's typically in rheumatoid arthritis patients who are one of the populations that get this problem. But that is just a small minority of the patients who suffer from SI joint dysfunction. So if you try to limit your surgical criteria to people who had a positive Mercedes-Benz sign on a bone scan, you'd be missing the boat. Right?
You really would be missing the boat.
Yeah, I think also that, for the folks out in the audience who are considering this for their practice, you're going to start out with cases that are very clear cut to you. And one example, which is a simple example is a patient that comes in who has essentially negative imaging studies, but's complaining of a unilateral pain in the upper buttock, lower back, and you palpate the dimple area, which is the right over top of the sacro-iliac joint on one side, and it treats the patient. In other words, the patient reacts to your very gentle palpation of this by jumping off the floor. And then you palpate the other side, which is not painful, and the patient has no reaction to it whatsoever. Well, there's obviously something going on there, and you've just done imaging studies, and they're all negative. So that is probably a very simple, almost patient who's almost serving as their own control to start out with. That's someone I think that would lead me down the path of considering SI joint dysfunction as primary diagnosis.
Cut yourself some slack, cut your patient some slack, take a chance, believe the patient that has been all over the city trying to find a reason for the persistent pain. Give them a chance to prove that it's not sacro-iliac joint. You can compress, you can rotate the iliac wings, you can do all the other descriptive physical examination ideas that have been presented, but consistently the most reliable is to take a chance with them, send them over to somebody who will inject their joint, assuming they have no other reasons. Now you go through that plethora of workup, but assuming that's it, then give them a chance and let them prove that they really are real, and because that's our obligation. Just because you've never considered it, you don't treat it, it's there. You just didn't know there was an answer for the treatment.
So that brings us to the physical exam, which is probably just worth a couple minutes. Ben, can I do this?
Yeah, absolutely. Just let me know when you're ready for questions.
So the one test that we're talking about is Fortin's finger test, and that's where you put pressure medial to the PSIS, to the posterior superior iliac spine. It's just a palpation. And the patients who really are sick with this, they jump off the table. And I'm not talking about the ones where you push anywhere and they jump off the table. I'm talking about it's a very focused pain. The Patrick's maneuver and Favor maneuver and lateral pelvic thrust, and the physical therapists are very sophisticated at some of these tests for the SI joint. I don't feel like in my practice it's sensitive or specific, and I can't rely on those things. I know that some of the physical therapists can, and they can be an asset to you, although sometimes I think that it gets overdiagnosed. I think the physical therapists are a big asset in diagnosis of SI joint pain because of its occult nature.
Absolutely. I agree with you. The number one physical examination that I use is Fortin's finger test directly over the PSIS, and oftentimes I get a very, very significant reaction to that on one side and not on the other. Of course, patients with bilateral symptoms will react that way on both sides.
Ben, you had a point.
Great. Yeah, we had a fantastic question come in from Dr. Houle up in Cape Cod. And I think there's going to be multiple different responses to this. So how often do you see bilateral presentation of symptoms? Do you treat it? And if not, how long before you would stage this operation? But given the posterior approach, I think I know your answer.
You want me to go first?
Sure, go ahead.
So I see it pretty regularly. Usually one side is worse than the other. But in my experience, a significant fraction of patients are demanding that I treat both. I've been in this space for a while, and I have patients flying from far away, many of them paying cash to have surgery, and they don't want to do this twice. And so I end up doing bilateral procedures frequently. I have no reservation whatsoever in doing bilaterals, and I do them as an outpatient. They go home the same day. And they don't have any more trouble than a unilateral. So in my experience is usually one side's worse, but often they're complaining about both sides and are actually requesting both sides be done.
I would, in my patient population, I think that I see about 50–60% bilateral. However, the bilateral nature of the disease sometimes requires the treatment of the significantly worse unilateral side before the patient will come back after having that side successfully treated and say to me, hey, you know what? My treated side feels so much better now. Now I know what a normal SI joint or back feels like, and you know, I'd like for you to test the other side, or I'd like for you to see me for the other side as well. In terms of bilateral procedures, I don't do them particularly often. I will stage the operation when I know and have confirmation that we're going to plan to do two sides. I will typically stage between 1 and 2 days between the operations.
Why do you think people even have bilateral sacro-iliac pain? I mean, because we have the audience, and a significant number of our audience are saying, well, I don't treat it, so if I don't treat it, I guess it's presuming either they don't know how to diagnose it, they don't know how to treat it, or they don't believe it's real. So I'm just going to take the next step and throw this back to you.
Well, so my answer to that is if the pathological motion is a rotation of the sacrum, that necessarily involves both sides. One side may be looser and more inflamed, but for that sacrum to rotate relative to the pelvis, they both have to be affected. It's sort of like having a unilateral C1 ring fracture. That doesn't really happen because it's a ring. If it breaks one side, it's got to break on the other. And so that's why I think that it is actually fairly commonly bilateral. It is said that fixing one side has a stabilizing effect on the other side for the same reason, and that many times if you have a minimally symptomatic contralateral side, you can just wait on that one because stabilizing the left is going to help the right, which was less symptomatic. Does that sound like a reasonable answer?
I think it does. If I could ask one more question, I don't know if the audience is interested, but how dramatic have you all felt the response to a firm stabilization and fixation of the sacro-iliac joint? Is this something that they get up and say, I'm ready to go party, or is it something that takes 6 months, like many of our fusions, to get well? What's going on?
Well, I've had experience with both types. I would say the overwhelming majority of the patients are reporting very significant satisfaction, decreased pain rates 80–90% in about a week or two. There is a sort of a tail of the population that I've had that takes several weeks, over 6 weeks, and I've had 1 or 2 patients, and I do not understand it, nor can I explain it, take about 3 months before they came back to me saying, this is really something that's helped me. I guess I shouldn't say I can't explain it. I have a theory, I have an idea, and that is that what's happened is that when there is a micro instability, let's say, of a weight-bearing joint, and if you use the analogy of your body being sort of like a building that has to withstand gravity, and the spine being its only weight-bearing column. Well, the end of that spine is placed into the ground, if you will, and the ground, in this case, is the pelvis. If there's a micro instability there, then I think the surrounding musculature, much like in a structure, the surrounding drywall, the windows, and everything else are going to be affected in the same way as the structure is unable to hold up what it needs to hold up. The musculature is going to adapt, and it may adapt pathologically.
So it's muscle memory is what you're talking about.
Yeah, absolutely. Spasm, we see that all the time after injury, etc. And then when you fix that joint, those muscles may not be able to sort of snap back to a more normal physiology and it may take longer. And that may be why a lot of these, not a lot, but some of these patients are out into the months category as opposed to 2 weeks.
Well, Dr. Rouben, I agree with Dr. Benalcazar. There is a spectrum and there is a range, but there is no doubt that a significant fraction of patients, it's like a light switch.
Yeah.
I remember you saying something about that earlier today.
It's we can approach it from many ways. This is certainly this technique that we're going to describe in greater detail later in the discussion is one whereby there's a lateral through the gluteal muscle technique, and it had a different spectrum of post-surgical responses because I was doing that 6 years before I transitioned to this. Is there, you want to?
Yeah, if we can go back to the bilateral discussion just for a second. We've got a patient, prospective patient, plus also a pediatrician, same person, who's a ballroom dancer and has bilateral SI joint disease. She's been treated with SI joint injections for quite some time now, and I think she's wondering how long is that sustainable? What is the impact of continuing to get SI joint injections? And so if you could just speak to that, and that'd be great information.
You want to take that?
Yeah, I've had a couple very young patients. I think my youngest patient so far was 18. But I've had others that started with SI joint dysfunction very young, and some of them, it took them 10 years to get to me, but they were gymnasts and dancers, people that spend a lot of time stretching, hyper flexibility, doing the splits, and that's the patient population that you see very young. So I think that it makes sense. You know, what I'm hearing already is a story that makes sense. The question is, how long is it sustainable to keep doing injections? Well, you know, that's something the patient's going to have to decide. If it's an acceptable strategy and the doctor is willing to keep doing it, it's fine. My guess is that's something that's going to end up being a surgical problem. How would you guys answer?
Absolutely. Presumably this patient is having injections with steroid. That by itself is going to present a problem and also a limitation to the duration of therapy like that. I think the key thing really is the patient's ability to go back to the activities that he or she loves. And it sounds like for this patient, because of the chronic nature of this, that she hasn't found a definitive treatment for this problem. And in that case, that is a place where surgery could benefit.
You know, I think that morally and ethically, as physicians, no matter what your specialty, again, our obligation is to do whatever we can to alleviate pain, and allow patients to return to what they consider a normal level of functional activity. And I think repetitive injections of corticosteroids, 1 after 2, 3, 4, 5, 6, 2 years, 3 years, is not the right way to go, because we know that intra-articular steroids destroy cartilage if it's repetitive in nature. We also know that in the case of a young person, certainly the pediatrician is seeing younger people in the case of either trauma or they have a mild form of Ehlers-Danlos where they're hyperelastic or they're gymnasts or whatever. You, as a physician, you have the obligation to expose your patients, once the diagnosis is made, to any and all legitimate and real treatment modalities, and let them make the decision. This is a technique that really, if done correctly, you're not burning any bridges. Remember, normal rotation in a plane is anywhere from 2 to 4 degrees, and certainly if you've had trauma, it can be more. Remember also, the sacro-iliac joint is not two surfaces flat together. They're undulated, and they have different varying concavities and convexities. So there's not much motion, but it can be overtly painful if there's ligaments that are lax and if they're banging themselves through that rotation enough that it makes them miserable. And if, in this case, the caller is expressing, I think we heard him say that he has patients, that he has proven this to be the case. This is an option for your patients, and if they're physiologically grown, then I think you ought to offer it to them.
And that brings us to, I think, the last step before we start talking about the surgeries that are available themselves, and that is, what is the treatment algorithm? We've made a diagnosis, we've identified the patient, and now what is the algorithm? What steps should these patients go through, and in what circumstances? Either of you guys.
Again, it all depends on the patient. I've had patients who come in and, neither one of us is that sure whether or not we're looking at an SI problem. And the reason is because the patient has pathology in the lumbosacral spine as well as seen on MRI. The patient may be elderly, the patient may have just undergone a trauma. And so time, therapy, injections, etc., I think even a belt perhaps that makes a lot of sense. Then on the other end of the spectrum are a patient that I've had that was actually an inpatient, brought in by the medical team, unable to walk, unable to move, unable to really even sit up in bed. Imaging studies didn't show anything that we would have expected like that. And then you run through the history and the physical examination. And in a case like that, we had no one to do the injections. We spoke to the patient about this. Everything seemed to line up. We decided to do the operation for this patient because this patient wasn't going anywhere otherwise. And it was a big, merciful thing for her. She did wonderfully well and was able to get up and move around. Why is that? Is it because I had all my boxes checked for diagnosis? No, this was a patient in a particularly unusual situation that required some thinking outside the box, and I was able to help that patient.
Before Dr. Rouben answers, I want to emphasize something you just said. What Dr. Benalcazar just said is he said he's treating his patients individually, one at a time, and that there is no one algorithm. And this is, I think, the biggest problem in modern medicine is everybody wants to know what the algorithm is, and they want us to treat every single patient by the same simple cookbook. And the three of us are all sitting up here tonight because we aren't that kind of doctor. We are the kind of doctor who looks at people one at a time, individually, and makes the appropriate judgment for that individual. And it is very hard to do that in modern America.
Right.
And it's sad.
Yeah, and the folks that are watching us and listening to this, you guys are many of you are spine surgeons, and so you run through this exact problem every time you diagnose a cervical spine, a lumbar spine. It's the same sort of thing. How long and to what extent do you employ conservative treatment prior to recommending surgery? And you know that means that the patient is involved in that decision as well as you, assuming that it's not non-life or function threatening. And so to answer your question without all of this extra stuff, I would say that in general, the patient presents, we run through the diagnosis, which basically is one of exclusion and inclusion. The exclusionary diagnosis for SI joint comes from imaging studies, where I am looking for lumbosacral reasons for the patient's pathologic symptoms. If I can't find those, then I have strengthened my case for a possible SI joint cause for the pain generator. This, of course, along with the history and the physical.
Okay, so we've made the diagnosis, though. Dr.
Yeah.
Rouben, do you have an algorithm, or is there a general rubric?
Well, again, I don't think it's an algorithm, because then it makes me believe that I can go to my local grocery and see the nurse who's got her computer, and you give her this litany of complaints, and she pushes a button and it tells her 4 different diagnoses and 10 different treatments for each of the diagnoses, and that's not the way medicine should be handled. That having been said, think about the diagnosis, confirm the diagnosis, offer the patient treatments such as circumferential constriction, iliac wing belts. There are people who believe that if you put a half-inch lift on the contralateral, the non-symptomatic side, tilts the pelvis and jams the SI joint and makes it more stable. There are certain muscle strengthening protocols that will help the pelvis and all the functions of the pelvis. And these are the types of things that you try. But just ignoring the patient and blowing them off and say, there's no such thing as a sacro-iliac joint pain. I don't have a treatment for it, but I forget that. Medicine and the art of medicine is a science as well. And you're obligated to yourself and your patients to learn everything that's out there, make your own decision whether it's real or not, but just don't blow it off. That's not fair to anybody.
So, you know, I talked to a patient in this room tonight who says that she thinks she has this disease, but she's able to keep it in check with physical therapy. And if she is, that's great.
That's awesome.
Right, and oftentimes the patient, sorry, just one last thing. Oftentimes the patient will stop your conservative treatment and say, hey, you know, I need to go on to a definitive thing so I can, you know, stop seeing you and your therapist every couple of weeks.
Right. Ben, another question?
Fantastic conversation. You guys have actually engaged this audience more than I thought you would. There's tons of questions on here. But one thing that kind of rings out as needing to be addressed is the question around previous hardware, whether that be another SI fusion system, whether that be S1 screws. Can you talk about, as we kind of transition into more procedural aspect of discussion, can you talk about the ability or capabilities of Rialto and the posterior approach when there may already be iliac screws, a competitive SI fusion system, S1 screws, S2 alar screws? If we can put that kind of in a nice little package, that would address 4 to 5 questions on here.
Dr. Rouben, go first.
Again, we go back to anatomy because this is not something that just, here we got a new operation and it's supposed to be minimal access and it's not supposed to hurt anything. And that's fine, but you still have to be a scientist. You still have to be an artist in your own craft. What's there? Well, you've got S1 screws. I've had patients who have broken through and the structural continuity, their S1 screw is no good. Again, you have to delete that as a plausible and possible explanation for your pain. 2, do you have a fracture? 3, does the fracture extend in many osteoporotics or whatever into the sacro-iliac joint itself? 4, if you have an alar screw that inadvertently goes across the SI joint, and how many guys do that? And they say, don't worry about that. There's no pain in the SI joint anyway. Well, we know there is. So these are all issues that we have to consider. 5, how about the lateral implants that transition across the gluteal muscle from a lateral approach and go from the ilium into the sacrum? Are they loose? Are they sources of pain? Is there scar within the gluteal muscle? These are all issues that have to be considered, and you have to take them one at a time and come up with a way of proving and disproving what is the true source of the pain. And if you're willing to take the time to do that, and your patient believes in you and trusts you and knows that you care, then you can work this out point by point and say, here's the list of plausible, possible reasons for your pain. Let's work together and find out what it is.
Dr. Rouben, in your experience, is it feasible that if there is previous hardware placed, as you just discussed, can you still do the Rialto procedure?
Well, the answer is maybe. It has to do with where the implants are. And number 2, are they loose, and are they themselves the source of the pain? Just because something is across the joint doesn't mean it's structurally stable. It could be loose as a goose. Well, that hurts. We know that any pedicle screws hurt if they're loose. So the answer is you may have to remove if something's there and definitively and properly stabilize it using the new technique.
Dr. Benalcazar.
So the most common hardware that I see is the S1 alar screw that gets in the way of the normal trajectory for the Rialto SI joint fusion. I use the O-arm navigation system, and so I have sort of an advantage over the folks who don't do that. I can see exactly where that screw is. It is absolutely possible to put in Rialto hardware with the existing S1 screws that may be in the way. If you think of the ala of the sacrum, and you think of the SI joint, it's a large joint. There is a lot of real estate there into which you can place at minimum 1 implant, and usually 2, even when there's an intrusive alar screw.
So let me ask pointedly, revising somebody else's SI joint fusion, somebody who had SI joint fusion done by a technique other than Rialto, are you willing to do revisions with the other procedures, and is there a success rate? I'll just start out by saying I have tended to avoid it. I think it's going to be a long run for a short slide by the time somebody has failed a lateral transgluteal approach, and that's been my preference. I would love for you to educate me otherwise, though.
I think, go ahead.
I was just going to say very quickly, I haven't seen that. Speaking theoretically only, if there was room, which there probably should be, even with a lateral three piston system, for example, if there was room to place a Rialto, there should be room to place a Rialto there. And if I was convinced enough, I think I would do that. I agree with you. I think it would be something I'd have to discuss with the patient.
What you'll find in some of the cases, not many of them, but and we have looked at patients who have had a previous lateral approach. Sometimes the implant is very proud and it sticks into the muscle, and that's the problem. Sometimes there is overt looseness around all of the implants or many of the implants. I think you're obligated to identify if those implants themselves are sources of pain, and I have no problem removing them because if I can prove, number one, that those implants are sources of pain either because they're not properly positioned or they're overtly loose, and or two, that I can delete the pain attributable to the sacro-iliac joint absent of those implants, then, I have problems ever saying a no to a stranded dog or anybody that needs my help, and that it frustrates the nurses in my office. But if you hurt, I'm going to do my best to help you.
So it's, I think in summary on that question, it's sort of like a failed back. It's doable, it's possible, it's not ideal.
Correct.
And I think we all feel that way, to various extents. Okay, so let's start talking about surgery. So the SI belt didn't work, and the chiropractor, it doesn't help anymore, but it used to, and the physical therapist was able to keep it in check for 10 years. We got a patient who needs something definitive done. What are the surgical options? What are the difference, and why is Rialto the right choice? I know what I think, but I want to hear what you guys think.
Well, having used both the lateral system and the Rialto posterior system, I think there are two fundamental reasons. Number one is the disruption of the patient's tissue during surgery. From a posterior approach, it's very clear to me that I'm going to be disrupting, and we have a video, we'll show it to you in a little bit, but I'm going to be disrupting a lot less of the patient's muscle and tissue otherwise in performing this operation, just to stabilize their joint. The second is surgeon comfort. As much as maybe a lot of people would say, well, I don't really care if you're comfortable or not, it helps that I'm comfortable so I can take my time and I can do the procedure as best as possible for the patient. So for those two reasons, I think that the posterior Rialto approach is significantly superior to the lateral approach.
Dr. Rouben, I know you feel strongly about that.
I did for 6 years before a lateral approach, and did I think it was successful? Yes. Did I have to deal with issues that I didn't think now in retrospect I should have to deal with? Sure. There are vascular structures within the gluteal musculature that bleed. There are neurologic structures within the gluteal musculature that become numb and hypersensitive. I think that as surgeons and physicians, we are overtly, ethically, and morally obligated to do whatever we can to relieve pain and do it without causing damage to the intrinsic structure of the patient.
Yeah, so I agree with those. In fact, that's really what led me to investigate the posterior approach to the SI joint. Was my first question was, what went wrong before? People did the operations like this 40 years ago, or did operations on the SI joint 40 years ago. Why didn't they work, and why were they abandoned? And my conclusion is number one, the surgical technique was excessively morbid and excessively dangerous. And that's because of when you go through undermine the gluteal muscle, you're causing muscle damage. You're also aiming directly at the superior gluteal artery. You are aiming directly at the S1 foramen, which you have to go to great pains to avoid, not to mention small nerves and other things that you can't see with a blind 6-inch poke across somebody's pelvic musculature. So one, the surgery was morbid on a population that was potentially sort of a sensitive population who is not going to tolerate a big surgical invasion. Number two, there was something wrong biomechanically, I thought, and that is because what they saw was a lot of pseudarthrosis. They saw a lot of loose screws with 30, 40 years ago with this lateral approach. And why is that? Well, if you think about the instantaneous axis of rotation of the SI joint, it is parallel to a laterally placed screw. And so that's sort of like putting a doorstop right next to the hinge. You have no mechanical advantage, and the sacrum is just going to rotate around that screw as a fulcrum. So what we sought to do in the beginning here was, one, view yourself as an unwelcome visitor. Do as little, make as little of a footprint as you can when you go operate on a patient. In fact, I do that with all surgery. I think that's why the trend towards minimally invasive surgery, we are unwelcome guests. And you don't go set up camp in somebody's guest room and stay for 6 weeks when they have you over. You disturb as little as possible and leave within 3 days, right? Well, the posterior approach is sort of like that. We disturb almost no tissue, and we're in and out pretty quick, just like a good guest should be. And in so doing, we are also achieving what I think, and this is my opinion, I don't have evidence to this, but I think a biomechanical solution which leads to superior fixation, very solid implants. I have not seen, I've been doing this for years now, I have not seen one loose implant. I've seen not one haloed implant. Have you guys seen implants halo?
No,
I haven't.
I mean, if it's done correctly and you follow the guidelines, you use whatever technique, whether it's C-arm, whether it's an intraoperative CT scanner, such as an O-arm, and you put it, and you understand your anatomy, and you preoperatively got a CT map of the anatomy, and you know where all the landmarks are, then you end up having a great result with minimal morbidity. I mean, remember, guys and gals, you don't need to do something that makes people worse. You need to do something that fixes the problem so they can move on and get back to their life. This technique does that. It's just simple as that.
Well, I think that's a perfect opportunity for us to move on to looking at some real surgical procedures. All three of us do this procedure slightly differently. I use the O-arm, and I don't navigate it. I just drill holes, put in K-wires, take a shot if I like my trajectory, place the implants, and then confirm it with a second O-arm shot.